glucose of more than 200 milligram per deciliter, with presence of metabolic acidosis, venous pH of less than 7.3, or serum bicarbonate of less than 18 milliequivalent per liter, and presence of ketosis. Ketone bodies in the blood of more than 3 millimoles per liter of beta hydroxybutyrate, or presence of ketones in the urine. This should be distinguished from hyperglycemic hyperosmolar state because in this, the blood glucose is more than 600, serum osmolality is more than 320, with absence of significant acidosis or ketonemia. It should be distinguished because the management is totally different. And diabetic ketoacidosis can be classified based on the severity as mild, moderate, and severe based on the degree of acidosis. In mild, venous pH is between 7.2 to 7.3, with bicarbonate between 10 to 15. And moderate is between pH between 7.1 to 7.2, or bicarbonate between 5 to 10. And severe is venous pH below 7.1, or bicarbonate below 5 milliequivalent. Yes, sir.
It's not the same one.
Yes, sir.
You can confuse.
Sure,
Less than
7 point. Yes.
3 to 1.
Yes, sir.
Sure.
Sir, that I look to up to date as well as PICU protocol. आगे बोलो. Okay. Yes. Coming on to the pathophysiology, DKA is the result of a critical or absolute deficit of insulin, which results in intracellular starvation of insulin-dependent tissue like liver, fat, and muscles. And this will stimulate the counter-regulatory hormones like glucagon, catecholamine, growth hormone, and cortisol. These hormones stimulate lipolysis as well as proteolysis and hepatic and renal glucose production and hepatic oxidation of fatty acids to ketone bodies. Unlike during physiological starvation, the absence of citric acid cycle processing of glucose impedes the processing of ketones for energy in diabetic ketoacidosis. The precipitating factors are poor metabolic control or missed insulin dose, illness, medication use like tacrolimus, glucocorticoids, drugs and alcohol, especially in pubertal age, and omission of insulin, which can be due to non-availability of insulin in poor countries, fear of hypoglycemia, fear of weight gain, or stress of chronic diseases. Coming on to the evaluation of a child with DKA, first and foremost is good history taking. In history, you can ask for whether there's any polyuria, polydipsia, weight loss, nausea, vomiting, abdominal pain, headache, restlessness, lethargy, or irritability. And coming on to the past history, you can ask whether the child is a known case of diabetes mellitus, whether there's any recent change in the insulin dose or regime, or whether there's any poor compliance to insulin therapy, or any past history of DKA. And coming on to comorbidity, whether the child had undergone any recent surgery, any psychosocial stress, any concomitant infection, or any eating disorder. Coming on to the clinical features, there can be anorexia, nausea, vomiting, abdominal pain. There can be like fruity odor in the breath, and polyuria, nocturia, vaginal or cutaneous moniliasis, lethargy, or obtundation. And coming on to the examination, there can be fruity odor in the breath. There will be features of dehydration. Weight loss will be there. Too small respiration will be there. And change in sensorium or coma, and papilla edema which will signify whether there's any cerebral edema or not, and abnormal pupillary reflex and posturing. Coming on to one case scenario, we have a 2-year 6-month-old female weighing 13 kgs coming to the emergency room at 10 at night with history of respiratory distress, vomiting, and pain abdomen for 7 days. On taking history of the child has history of polyuria and polydipsia around last 15 days. And there was history of weight loss around 2 kgs over the past 1 month. So how do you proceed? First, you have to confirm whether the child is having diabetic ketoacidosis or not. As I have mentioned in the previous slide, hyperglycemia of more than 200 and metabolic acidosis. Sir, known case of type 1 DM with history of polyuria and polydipsia and vomiting and pain abdomen.
No case of type 1 BM, what untreated, because unprepared. No case of type 1 BM, which should have presented according to point examining top treatment of something.
Yes, sir. Known case treated but not compliant to treatment. So step 1 is confirm the diagnosis whether there is DKA or not, which I have mentioned in the previous slides also. And you classify severity in whether there is any mild, moderate, or severe. And steps in management like correction of dehydration, correction of acidosis, and reversal of ketosis, restoration of blood glucose to near normal, and avoiding complications of therapy like cerebral edema, and identification and treatment of the precipitating event, and prevention of recurrent episodes. And on doing VVG in the patient, the pH is 7.03, which is coming on to the category of severe DKA with bicarbonate of 6.8, and CBG was more than 500. And urine ketone by ketostic was around 4 plus, was large, and glucose 4 plus. So in the initial step, what we had to do is like we have to obtain 2 intravenous access, keep one of them heparin low for painless repetitive sampling, and we'll send the following investigation like serum glucose and electrolytes, venous blood gas, blood urea and creatinine, complete blood count and blood culture and sensitivity, urine ketone by dipstick, chest X-ray, HbA1c, anti-TTGA, hydrofunction test.
Also, culture.
Yes. Okay.
Infection, blood count, and blood.
Yes. And fluid replacement is one of the most important treatment modality in diabetic ketoacidosis. And it should always start 1 to 2 hours before giving insulin therapy to prevent cerebral edema. Fluid replacement can be calculated as mild, moderate, and severe, around 30 to 50 ml per kg in mild, 50 to 70 ml per kg in moderate, and 80 to 100 ml per kg in severe DKA. We'll start with 10 ml per kg of 0.9% normal saline administered over 60 minutes. And additional fluid boluses can be given based on the circulatory status of the child. In our child, the body weight was around 13 kgs, and maintenance fluid for 48 hours comes up to be 2,300 ml, and fluid deficit of the child was around 1,105 ml, and the total fluid to be given over the next 48 hours comes out to be 3,405 ml. And the child already received a bolus of 10 ml per kg normal saline, and total bolus was 130. So the fluid infusion rate is calculated as 3,405 minus 130 divided by 47, which comes out to be roughly 70 ml per hour. And the fluid choices are normal saline or Ringer lactate. Then for the first 4 hours, continue with normal saline and change over to half normal saline till blood glucose comes to 250, and shift to half DNS when blood glucose is less than 250. And with giving fluid, we should also start insulin therapy. The dose of insulin is at 0.05 to 0.1 unit per kg per hour. And higher dose are associated with increased risk of hypokalemia, hypoglycemia, and to rapid decline in the serum osmolality, which can predispose the child to develop cerebral edema. And lower rates may be inadequate to suppress ketogenesis. Preparation: 50 units of regular insulin is diluted in 50 ml of normal saline to arrive at a standard insulin concentration of 1 unit per ml.
For the multiplication size,
Yes,
how to write the multiplication? If you cannot find out, then write the next.
sure, sir.
Okay.
Yes, sir. An alternative calculation is like body weight into 5 divided by 40, which will be the required insulin in ml, and you dissolve with NS to make 50 ml. And timing of insulin therapy is to be started 1 to 2 hours after giving fluid replacement. And before starting insulin therapy, you should always prime the tube with insulin, because the insulin will get stuck onto the IV tubes and IV cannulas. So priming of the tube is necessary.
Why do you start after 1 hour?
That it can lead to development of cerebral edema if started early. And duration of therapy: the duration of therapy is administered at the same rate until the resolution of ketoacidosis, which can be detected by increase in the pH, bicarbonate, and closure of the anion gap. And dose adjustment: following starting of insulin therapy, the blood glucose is expected to fall at a rate of 36 to 90 ml per deciliter per hour. And if hypoglycemia occurs despite increased dextrose solution, the dose of insulin may be reduced to at a rate of 0.02 units per kg per hour, up to 0.05 units per kg per hour, provided the metabolic acidosis resolves. And clearance of ketone is not the endpoint of therapy with intravenous insulin. In urinary ketones, the main ketone which is detected is acetoacetate, whereas in cases of DKA, the main ketone which is present in the blood is beta hydroxybutyrate. So the resolution is associated with return of elevated beta hydroxybutyrate to acetoacetate ratio, which initially can be 10:1 during the first episode of first presentation of the in the emergency room, and after giving insulin, the ratio can become 1:1. And potassium replacement: potassium should be added to the fluid at a rate of 40 milliequivalent per liter, that is 2 ml per 100 ml of fluid once the child has voided. And adequate urine output is ensured, and potassium and ECG monitoring is done frequently to prevent hyperkalemia or hypokalemia. And the maximum recommended rate of intravenous potassium replacement is 0.5 milliequivalent per kg per hour. And if hypokalemia persists despite a maximum rate of potassium replacement, then the rate of insulin infusion can be reduced accordingly. And phosphate replacement: total body phosphate is depleted in DKA due to movement across the cell wall and osmotic diuresis. Intravenous phosphate replacement is reserved for serum phosphate less than 1 milligram per deciliter in such cases with close monitoring of serum calcium. And bicarbonate therapy in DKA usually responds to fluid and insulin therapy, and administration of bicarbonate is seldom necessary. And there's no clear outcome advantages demonstrated in patients receiving bicarbonate for DKA in children. And therapy with bicarbonate may be associated with increased risk of hypokalemia, hypernatremia, or worsening of CNS symptoms. And bicarbonate therapy can be considered in children with cardiac dysfunction, which is secondary to profound acidosis, or in children who have life-threatening hyperkalemia. And the gold standard of care of DKA is regular and vigilant monitoring. And we should do an early monitoring of the heart rate, the respiratory rate, the BP, and the hydration status, along with the neurological examination. And fluid intake, urine output, and insulin administered should also be monitored. And as always, the CBC should always be monitored. And every 2 to 4 hours, with the a very nice channel that we have kept. Electrolytes should be sent. Blood urea should be there. Blood urea should be sent. Hematocrit, venous blood gas, urinary ketones, and ECG should be.
Why are you taking urinary ketones? You have mentioned that the resolution of ketones is not the endpoint of my test.
In mo-
Financial expense.
in-
It costs money for the patient.
Yeah, but in most of the center, we don't have facilities to detect beta hydroxybutyrate.
No, but we need to hear taking blood gas. What
Huh.
will be the endpoint of your therapy? Urinary ketone. No.
No,
Then why are you checking? What
And
will
it takes a
that,
longer time.
Yes.
For the patient
yes,
to improve. After that also ketones are.
yes.
what we actually do is we check the correction of acidosis and we look for the closure of anion.
Anion,
Closure of
yes.
anion is a very sensitive marker for the endpoint of insulin resistance therapy. We do not need to monitor 2 to 4 hours insulin resistance.
Okay. And when do we transition to subcutaneous insulin therapy?
Here, that glucose is, I have never checked my whatever. I've checked my urine. So that anything my blood sugar is normal. And if my blood sugar is at a normal level, my sugar have the ketones.
Yes, sir.
Unless and until I have the
Dehydration
dehydration
or infection.
It's not in my mind.
And when do we start oral transition to subcutaneous insulin therapy? When to start oral fluids? Like oral fluids should be introduced only when there's substantial clinical improvement, where the metabolic acidosis has been corrected, and the patient indicates a desire to eat. As oral fluids are advanced, intravenous fluids are reduced and changed to subcutaneous insulin is planned. And the ideal time for beginning of administration is just before a meal. And to avoid any rebound hyperglycemia, rapid acting insulin are administered subcutaneously 15 to 30 minutes prior, and regular insulin is administered 1 to 2 hours prior to stopping insulin infusion. The dose of subcutaneous insulin in patients with non-diabetes insipidus or the normal usual insulin regimen should be started. Whereas for patients with DKA disease onset, the recommended total daily dose for pubertal age is 0.75 to 0.1 units per kg, and for pubertal children is 1 to 1.2 units per kg. And start with regular insulin 4 times per day. And monitoring of blood sugar should be done 5 times per day before breakfast, lunch, dinner, midnight, and at 2 a.m. or 3 a.m.
Where are they?
Yes, sir.
In the morning, you do a free breakfast,
Yes, sir.
and after lunch, you do the full lunch,
Yes, sir.
and then again free. So next day, you repeat. That's
But at least
Yes, sir,
40
yes, sir.
hours, you should have at least 1 free and 1.
Yes,
And
sir.
the most common reason for decreased compliance is parents who want to treat the child's home.
Uh-huh.
सबका treatment and on top of that, you can treat the child's home types of disease.
চারটে তারপর যদি তার সাথে ল্যান্টাস থাকে
Yes.
তারপর যদি চারটে সুযোগ থাকে
And
Yes,
at
sir.
home, they don't want to hold the child. I'm not doing that. But don't say, mom, actually, CBD treatment was a problem. Another thing that you should mention is not just the dose, but total dose calculation.
Yes, sir.
There is something called insulin. How much the sugar will volume of insulin decrease. I mean, the sliding scale that is based on that. If you're giving aspart, that is 1800 divided by the total insulin required. That will be the amount of sugar that will decrease with 1 unit of insulin. So your insulin scale that you are making, that will be based on that. Okay. So that you have to mention, and that is important also for advising the patient about sick day management.
Yes.
That if your sugar is coming higher than this, give this much extra amount of insulin.
And complications of DKA can be hypoglycemia, hypokalemia, cerebral edema, inadequate dehydration, cerebral venous thrombosis, arrhythmia, which can be secondary to this electrolytemia, and prolonged QT interval. And rare complications can be DVT, intestinal necrosis, rhabdomyolysis, and pulmonary edema. And infections like mucormycosis can also be present. And coming on to one of the most dreaded complications of DKA is cerebral edema. And it is detected in only around 0.3 to 1% individuals presenting with DKA. And this is responsible for around 60 to 90% of all the deaths in DKA. And the risk factors include age less than 5 years, new onset diabetes, prolonged duration of DKA symptoms, and presentation with severe acidosis. And therapy associated risk factors could be like use of bicarbonate, rapid decline in serum osmolality, higher volumes of fluid infused in the first 4 hours, and early administration of insulin within the first hour of treatment. And there is a criteria, Muir's criteria, which determine the clinical cerebral edema risk, which is divided into diagnostic criteria, major criteria, and minor criteria. Out of this, 1 diagnostic criteria or 2 major criteria or 1 major and 2 minor criteria will have a sensitivity of 92% and specificity of 96% in recognition of DKA cerebral edema, which is early enough for treatment of for effective intervention. And coming on to the management of cerebral edema, the head end of the bed should be elevated if there is no hypotension, and fluid administration.
Should be the midline. Should be the mid.
Yes, midline. And fluid administration rate should be reduced by 1/3, and the airway is secured. And if warranted, intubation should be done and mechanically ventilated.
What should be the schedule of intubation in a child with diabetic grasp? Because child comes severe also. Severe distress is there. The sensorium is altered. What should be the threshold for intubation of a DKA child? And why?
The threshold should be low because the child presenting with DKA can also, and decreased sensorium is mainly pointing towards developing cerebral edema. Or
the intubation threshold of DKA patient is supposed to be very high. Why? Because when the child is hyperventilated, the CO2 of the child is very low. When you're trying to intubate the child, there's a transient rise of ETCO. After you intubate the child, you will see the ETCO to be 20. But even the 20 is high for the child, because maybe initially it was maintaining at 5. So that transient rise in CO2 is because cerebral vasodilation, the carbon dioxide vasodilated to the brain. That will worsen the cerebral. So the intubation threshold of a DKA has to be very high.
and intravenous mannitol or 3% normal saline can be given, and the dose is repeated if no response is perceived within 30 minutes to 2 hours. And following institution of therapy, a cranial CT is ordered to rule out other treatable cause of neurological deterioration like thrombosis or any hemorrhage.